Hi everyone, my name is Stephanie Lex and I'm going to be talking to you guys today about delirium. Um, I'm the only one who selected this topic for our class, so it's just going to be me presenting today. Okay, so let's begin with the overview. Delirium is described as a state of confusion that has a very quick and very sudden onset of symptoms. And these symptoms can actually last from a few hours to several days. However, it is usually reversible if it's treated in time. Delirium is actually different from dementia, even though oftentimes people coincide them with one another. But dementia is actually a gradual progression of these symptoms and usually leads to permanency, like something like Parkinson's disease. Um, Delirium is also one of the five neurocognitive disorders or NCD. And one of the things that sets the disorders apart in this segment of mental health disorders is the fact that the impaired cognition that usually occurs with these is not congenital. In other words, you're not born with it or it doesn't develop in early childhood. And also, the deficits or the symptoms that you experience, they're acquired rather than developmental. Um, and one other thing that's really unique about the neurocognitive disorders is the fact that the underlying pathology and the etiology of the diseases can usually be identified or determined, I guess, by testing and other the presence of other specific biomarkers, like whether or not it's in EEGs, some blood work, and things like that. The criteria that a lot of the neurocognitive disorders are based around, there's based on five domains, and it usually deals with complex attention, executive functioning, learning and memory, perceptual motor abilities, and social cognition. And delirium, we'll touch on some of these as we go through the presentation. So delirium actually has a very early debut in, I guess, social literature. One of the early stories actually was from Charles Dickens, when he became editor of the Pickwick Club or the Pickwick Papers, and one of the periodicals that got released was one called The Stroller's Tale, and it had a really great description of what delirium looks like. And here's an excerpt from it. I sat there for upwards of 2 hours, during which time he tossed about, murmuring exclamations of pain and impatience, restlessly throwing his arms here and there and turning constantly from side to side. At length he fell into a state of partial unconsciousness in which the mind wanders uneasily from scene to scene and from place to place, without the control of reason, but still without being able to divest itself of an indescribable sense of present suffering. And so if you continue reading that chapter, actually, it's pretty interesting. It's about this old guy who basically slowly loses his mind. Well, not slowly, but actually over the course of several days. And the narrator watches this happen. So some of the predisposing factors that are associated with delirium are older age. The elderly population actually has a very high prevalence of delirium. Dementia, which is one of the diseases we talked about earlier. Certain comorbidities, such as physical injuries, such as like a break of the femur, presence of cancer, some cardiovascular diseases, and also some psychiatric comorbidities such as depression. Another predisposing factor is impaired function. So a lot of elderly individuals who live in nursing homes or are not able to care for themselves, they're at a greater risk for delirium. And also a history of alcohol and or substance dependence. So some of the signs and symptoms associated with delirium are confusion, agitation, delusions and hallucinations, and an affect that's withdrawn or of decreased energy. And patients with delirium uh, experience diminished functioning. And as I mentioned before on the previous slide, it places them at an increased risk of being institutionalized. And for older patients, especially those that are institutionalized, the risk of delirium increases threefold. Older hospitalized patients are at a greater risk for developing delirium. This ranges from 10 to 14%. And delirium is also often presented in the emergency department of hospitals, and usually anywhere between 10 to 30% of cases of delirium actually begin there. And this risk also increases with age. So the older you are, especially if you're 85 years and older, it increases your risk by upwards of 14%. So some of the diagnostic criteria to consider when trying to diagnose your client or patient with delirium is a disturbance in attention, a sudden onset of abnormal or uncharacteristic symptoms, other disturbances such as a deficit in memory, the patient appears disoriented, there's a change in language or verbal ability, changes in vision and perception. There's also changes or disturbances that can't be explained by other pre-existing illnesses. So like, for instance, if the patient doesn't have dementia, but they are experiencing delirium, then that's something to definitely be aware of. And also the patient's assessment finds that changes are attributed to another medical condition, such as substance intoxication or withdrawal. But in all cases, early recognition for delirium is key. If you actually look in our text that we have, The Essentials of Psychiatric Diagnosis, Francis actually talks about how delirium usually ends in one of three ways. The patient either gets worse, they go into a coma, or they die. It's kind of morbid. So some additional considerations when diagnosing delirium is major neurocognitive disorders, dementia with superimposed delirium, delirium that's due to multiple etiologies, substance intoxication or withdrawal, primary psychotic disorder, a primary diagnosis of bipolar depression or anxiety disorder, acute stress disorder, or the patient suffers from post-traumatic stress disorder, or malingering, also known as they're just lying. There's nothing really there. When diagnosing delirium, there's a few things that you might want to keep in mind. It's important to rule out any of the diagnoses that I just mentioned. And it also is really important that you try and go for a second diagnosis, especially if you're considering the severity that this delirium may pose. Because delirium doesn't just affect the cognitive functions, but is actually system-wide. So when considering these other disorders, especially in the presence of hallucination, which is a hallmarker of delirium, take into account the patient's age. As I said before, older individuals are affected more often, and the frequency with other conditions. And also there are certain diagnostic tests that can confirm the presence of delirium, such as an EEG. So when either dealing with the patient or the person who's usually accompanying a patient who's suspected of suffering from delirium, several questions to consider when asked or trying to get more information. If you're talking to the informant, you just ask them if this behavior that their loved one is actually exhibiting, if it's something that is out of the ordinary, and if there's a heightened level of confusion that they're experiencing. And additionally, with the patient, there are several questions to consider, such as asking them if they recognize the person that brought them in, or if they're aware of why they've actually been brought into the hospital or the health facility. And you also ask them if they know where they are, if they know the year, if they know certain current events, like who the current president may be, and also other questions that test their cognitive ability, like asking them to spell certain words or subtract or add certain numbers from other numbers in a sequence. So when you're trying to code delirium using the ICD-9 coding, one of the things that I noticed is that delirium itself is actually coded as 293, but the severity of the disorder can have a separate code accompanying it, going with it. Sorry about that. From mild to severe, or whether there's not another disorder present with delirium. So if you're looking at delirium that's caused by certain substances, the way you determine that is if the criteria from A and C, the symptoms associated with those criteria are very severe and require immediate attention. And so that can be caused by either alcohol or opioid substances, sedatives, stimulants, or any other medications that may be unknown. And with other medications, such as if criteria A and C are a side effect of prescribed medication. So it's not always a situation where illegal substances or controlled substances are present. It can also, again, be from opioids, sedatives, stimulants, and other conditions. And that asterisk that you see up by that heading for medication, this is also the same code is used for multiple etiologies as well. And one other thing I should mention, again, because the elderly population is affected at a much higher rate than others, it's definitely important to consider the medications that they're on, because elderly patients tend to they tend to have a drug regimen that includes multiple drugs, some of which may interact really badly with one another and possibly cause delirium. So I found this really short video. It kind of goes over delirium and for delirium awareness, and I'm going to play it for you.
Delirium is a medical emergency and can affect anyone. However, certain people are more at risk than others. Those at risk include people over 65, people with a dementia diagnosis, people with infections, and people with a fractured femur. Delirium is indicated by a sudden change in a person's behavior. There are two types. Hyperdelirious, the person is agitated or maybe having hallucinations. Hypodelirious, the person becomes withdrawn. There can also be a mix of the two behaviors. This unexplained change is very disturbing for family and carers. Meet Frank. Frank is an active, independent gentleman of 71 who is currently living alone. Every morning, Frank's daughter Kate calls in for a coffee and a chat. This morning, however, Frank just isn't himself. He's refusing to eat his breakfast and keeps mumbling about his food being poisoned. After 2 days of this changed behavior, Frank has been admitted to hospital. He won't answer the medical staff's questions and keeps trying to leave. He is anxious and withdrawn. Kate tries her best to pacify Frank, but he is increasingly agitated. He refuses to eat or drink for staff and has started hallucinating about rats on the ceiling of the room. The doctor informs Kate that Frank has a chest infection, but Kate doesn't think this explains his behavior. She tells medical staff that her father doesn't normally act like this. The nurse treating